It's a pleasure to be here. Can everybody hear? Okay. We're not going to repeat too much of what was said yesterday, but I did want to still give an overview of PANS and PANDAS, just in case there were folks who weren't here before. The subgroup of children with abrupt onset neuropsychiatric disorders, which we have nicknamed PANDAS if it's triggered by strep, and PANS if it's not, includes about 1/4 of children who have obsessive-compulsive disorder. And from older epidemiologic studies, we know that 1 in 100 children have OCD, so by extrapolation, approximately 1 in 250 children will be impacted by obsessive-compulsive disorder of an acute onset, PANDAS and PANS. The medical model for PANDAS is Sydenham-Chorea, which was described in the 1600s by Thomas Sydenham. It was actually described by a Frenchman, de Bayeux, 10 years earlier, but because Osler was the one that gave it its name, he chose his English friend Thomas Sydenham. And Sydenham-Chorea is the neurologic manifestation of acute rheumatic fever. The video is working today, so you can see this young girl looks extremely fidgety, but as you notice it when she tries to cross her legs, then her arms flail about. When she nods her head, then her shoulders go, and she just has a cavalcade of adventitious chorioathetoid writhing movements that interrupt her ability to sit still. She has eye blinking, and what you'll see in just a moment is the pathognomonic sign of the milkmaid's grip, in which, because of a failure to sustain tetanic contractions, the child grasps and releases the examiner's fingers. And parents might actually be the first to observe this as they're holding their child's hand across the street, and it just feels very strange to have them keep letting go at different points in time. Well, what you can't see here is that this young girl had an abrupt onset of obsessional worries about something bad happening to her mother and to her brother, who she didn't actually particularly like. But she was quite consumed with these worries, and they had started about 2 to 4 weeks before her movements began. In these video, you can see that she's trying to keep her eyes shut, and she can't. She's also protracting her tongue, and it wasn't able to sustain that. So that inability to sustain tetanic contractions, as well as the presence of the adventitious movements, is what characterized Sydenham-Chorea. We were not actually the first to describe a relationship between Sydenham's and OCD, as it had actually been present in the earliest reports of the disorder, with Osler describing perseverativeness of behavior, and a 1900s JAMA article talking about a variety of very severe obsessive symptoms in patients with Sydenham-Chorea. In the 1950s and 60s, there was a note that patients who had obsessional neurosis were more likely to have had a personal history of Sydenham-Chorea as a child. And then we did 1 retrospective and 2 prospective studies at the NIMH that showed that about 2/3 to 3/4 of children with Sydenham-Chorea had significant obsessive-compulsive symptomatology, always starting before the movements actually began. And importantly, children who had rheumatic heart disease but did not have the neurologic manifestation of rheumatic fever, i.e. Sydenham-Chorea, they did not have an increased rate of obsessive-compulsive symptomatology. Our colleagues in Sao Paulo, Brazil, followed on this line of research and documented that with recurrent episodes, the frequency of obsessive-compulsive symptomatology actually increased to 100%, with all children having OCD. And in those patients, the obsessive-compulsive symptoms then began to persist beyond the choreiform movements. So our hypothesis was that since the OCD can start before the Sydenham-Chorea, that it might be a form fruste of the illness, and we speculated that when chorea was absent, the post-streptococcal obsessive-compulsive disorder could be identified, and we labeled that as PANDAS. It's characterized by an unusually acute or abrupt onset of the symptoms, and then an episodic relapsing and remitting course in which every time the child is exposed to a strep or infected with strep, the symptoms dramatically worsen, they get better over time, and then they'll get worse again. This is a disturbing video if the sound plays, so I'll warn you in advance that I can only stand to play it for a few seconds. What the girl is asking is that she be killed by the doctor, that she needs to be killed. And the reason was because she had developed an acute... She had developed an acute onset of obsessive-compulsive symptomatology, very severe depression, very significant anorexia. And the reason that I'm showing this, and I'm just going to turn this immediately around to the fact that we will not have this happening in Saskatchewan anymore because of this wonderful conference. That was the 10th doctor that she had seen to try and get help. So the network that's being established here is so tremendously important, and we are very, very grateful to the families and to Dr. Rosenberg for making it happen. In addition to the very horrific presentation of symptomatology, much more typical is the child who has an abrupt interference with their life in the presence of a significant pattern of comorbidity, everything from separation anxiety, unable to leave home or leave their parents, behavioral regression at a 10-year-old boy who suddenly needed to talk baby talk and was playing with his youngest sibling's toys, hyperactivity, learning difficulties, tics in about 3/4 of the children. 20% in our early sample had an eating disorder. Dr. Murphy has just done a study showing it's actually closer to 50%, and hallucinations are present in 10% of the children. On the right in pink are the physical symptoms that also accompany this illness, and I think it's those that can separate the PANS cohort from a typical child with OCD, anxiety disorders, and depression. And that is the fact that they have an abrupt onset of urinary frequency, urgency, and enuresis. They have changes in their handwriting, short-term memory losses, and sensory changes, as well as a very significant symptom is the abrupt onset of sleep disorders. Well, PANS is, as I told you already, the larger class of children with acute onset, and it has the advantage that the diagnosis can be made the very first time a child presents to a clinician, because all you have to do is recognize the pattern. All you have to do is say this was an abrupt onset of symptoms, and not only did they have OCD or an eating disorder, but they also had at least 2 of the 7 categories. And on average, the children in our study, as well as in 2 community samples, had 5 of the 7 categories. So it's affecting cognition, it's affecting emotional ability, and it's affecting their will in terms of their obsessive-compulsive symptomatology. The eating disorders of PANS-PANDAS are quite characteristic as well, and they're of 2 types. The first type is the child who has a very significant obsessional fear, a fear of vomiting, a fear of contamination, fear of choking, fear of not being good enough to eat, which was what that young girl's symptom was. We've followed the children or gotten the histories and noticed that once the weight loss exceeds 10 to 15% of the body weight, even if that's only 5 pounds in a 50-pound child, then the body image distortions begin, and the child begins to worry that they're too fat, that they're ugly, or that other symptoms develop. In a very small fraction of patients, 2 of the boys in our Sydenham, Korea sample, the first symptom is actually the body dysmorphia, and they restrict food and exercise excessively in an attempt to lose weight and to become thinner. 2 recent studies that are just in the process of being submitted for publication out of our group were done in the IVIG trial that we just completed, as well as a cohort of children who are participating in a natural history study. We did routine and overnight electroencephalography, or EEG, and found abnormalities present in 7 of the 42 children studied. That 17% had sharp wave epileptiform activity, or they had nonspecific diffuse or focal slowing. Both of those are signs of inflammation of the brain, an encephalopathic process, and in conjunction with the other aspects of PANDAS, they actually meet criteria for an autoimmune encephalitis, a true inflammatory disease of the brain. The polysomnograph abnormalities were present in 12 of 14 children studied, or 86%, and included everything from non-REM parasomnias, those are the bad dreams, the sleepwalking that we heard about earlier today, The periodic limb movements of sleep, which are typically found in individuals with ferritin and iron deficiencies, but in our children they did not have iron deficiency as an explanation. And then most interesting from a sleep architecture standpoint is the presence of REM behavior disorder and non-specific REM motor disinhibition. During REM sleep, which is the rapid eye movement sleep when you're dreaming, you're supposed to have complete atony of your muscles of your body so that you don't move during your dreams and you can't act out your dreams. And you've heard some of the drug ads. There are drugs that inhibit that, and people perform all kinds of things during their sleep. But in this particular condition, the children were not on medications and yet were exhibiting those same kinds of abnormalities. We recommend in the Journal of Child and Adolescent Psychopharmacology, and you have the article in your packet, there is a very structured diagnostic workup for patients with PANS. Because it's a diagnosis of exclusion, you want to make sure that the child doesn't have an infection, they don't have lupus, they don't have another explanation for their abrupt onset of symptomatology. So there are labs that need to be done. And one of the most important is to do a throat culture to make sure the child doesn't have a current strep infection, which, if treated, might actually relieve their symptoms. We found positive anti-nuclear antibodies, or ANAs, in 40 to 50% of our patients versus about 10% of healthy controls. The ANA is frequently positive in lupus, but it's a non-specific marker, and we believe that it just represents increased cross-reactivity, much as the Cunningham panel does. Abnormalities of cytokine and chemokine profiles might point you to a specific etiology for these symptomatology. The HLA subtype vulnerabilities, I don't know if Dr. Crowley is going to talk about that, but that's certainly a genetic vulnerability that is worth exploring. And then finally, the presence of the cross-reactive antibodies. Work that we've done with Dr. Madeline Cunningham over the last 25 years has documented very nicely that children with Sydenham chorea and children with PANDAS have very similar abnormalities in terms of antineuronal antibodies. Fairly consistently, though, there are differences in exactly the type of the distribution, and one of the very active lines of research is to see if we can't identify what those antineuronal antibodies actually are recognizing on the medium-sized neurons with which they react. This panel shows 3 patients. The bright red, is acute titer. C, the hashed, is convalescent for 3 separate patients there, subject 1, 2, and 3. And what you can see is that the titers are higher during acute illness than they are during convalescence, particularly among patients who had a rapid improvement in symptomatology. The anti-lysoganglioside antibody had been found by Dr. Cunningham in her work on rheumatic heart disease. She also reports that antitubulin antibodies are high, as are anti-dopamine D1 and D2 receptor antibodies. I actually prefer this panel because it's not clearly described what the antibodies are reacting to, but what we knew from early studies with Pat Levitt was that depending on the child's symptoms, you would see different patterns of staining, with greater staining, greater reactivity against the caudate if the child had obsessive-compulsive symptoms, against the putamen if their primary presentation was tics, and against the triad of caudate, putamen, and globus pallidus if the child had the classic triad of OCD, tics, and ADHD. Notice here on the far right side that Tourette's and OCD controls were negative, as were healthy children. This is extremely important because a lot of the controversy surrounding PANDAS has come from the negative studies of PANDAS children, but in actual fact they were studying non-PANDAS Tourette's and OCD, and so it wasn't surprising that they didn't find the antibodies present. Among children with PANDAS, the presence of these antineuronal antibodies in their serum appears to have bioactivity as measured with the CAM kinase 2. And here what you see is that the children, samples from children with Sydenham chorea in the red on the left-hand side are approximately 200% greater activity than would at baseline. In the PANDAS group, it's about 150%, and in the non-PANDAS cohort, it's lower. And Dr. Cunningham previously had set the cutoff at 140 because none of the healthy controls had values above that. I just talked to her, and she now is using 130, which means that you might have a positive Cunningham panel, and particularly on the CAM kinase, even in a child who does not have PANS pandas. So for the clinicians, it can be helpful as a confirmatory laboratory test, but is probably not useful as just a diagnostic test in the classic sense of you don't want to send off the blood to try and make the decision about whether or not the child is affected with pandas and PANS. Removal of those antibodies appears to be quite effective in this post-infectious misdirected immune response. And here what we see is that children receiving IVIG had on average a 40% reduction in their symptom severity over the 1 month after infusion of 1 gram per kilogram on each of 2 consecutive days of IVIG. Children who received a sham IVIG infusion, just salt water instead of active drug, had virtually no change in their severity scores, whereas those who got 5 single-volume plasmapheresis treatments over the course of about 10 days had almost a 65% reduction in symptom severity. And I can't show you how it looks in the clinic to watch the children's obsessive-compulsive symptoms and their other neuropsychiatric symptoms of PANDAS disappear, so I thought I would show you a typical example of one of our patients with Sydenham chorea. And unlike that little fidgety girl, this young woman has the weakness as her primary symptom, her Sydenham's chorea. And she has to be lifted up out of the chair. She's got that floppy marionette or puppet. And as she tries to walk, if you watch her toes and her hands, they'll just flail about with each step that she tries to take. Extreme weakness, a lot of chorioathetoid movements. She was unable to brush her teeth, dress herself, and obviously she couldn't ambulate. Because she was from Los Angeles and she had come to the NIH, we were worried about sending her back home, so spent the 2 weeks she was in the hospital working with our physical therapy department to get her lift belts and wheelchair and etc. Whoops. But this is how she actually left us, so we didn't need to use any of those things. Come on, walk. She was able to perform all of her ADLs by the time she left the hospital, and what you can't see in this video is the fact that she came in with 2 to 3 hours a day of obsessive-compulsive symptomatology, a variety of contamination fears, fears of harm coming to herself or to family members, lots and lots of ritualization, and that was also gone at the end of that time. With that, I close.